Hello, my name is Bev Riediger, and I want to welcome you to a new episode of Network Voices Conversations interview series. In this series, members of the Marathon of Hope Cancer Centers Network Patient Working Group chat with network researchers and clinicians about topics that matter to us. Before we meet today's guest, I'd like to introduce ourselves. I live in Winnipeg and have been a member of the MOHCCN Patient Working Group since its inception in 2023. I have had breast cancer twice, where I was first diagnosed in 2005 and again in 2020. I've been a Cancer Manitoba volunteer since 2006, when I became a regular contributor and member of the editorial board of Our Voice, which is a patient-run Cancer Care Manitoba publication. I'm currently a Cancer Care Manitoba patient advisor and a patient partner of the Health Services Research Lab at Cancer Care Manitoba's Paul Albertson Research Lab. I'm also a mother, grandmother, and an amateur writer.
Hi, thanks, Bev. My name is Dan Murphy. I'm a husband and father of two daughters living in Toronto. In June of 2023, I was diagnosed with stage 4 pancreatic cancer. And while it was a very tough prognosis, here I am living with remarkable quality of life nearly 3 years later. This is because of precision medicine and an outstanding care team taking care of me. Along with being a MOHCCN Patient Working Group member, I'm also very proud to be contributing my genomic and treatment data to the MOHCCN's Gold Cohort, which is providing researchers with a wealth of data, helping them better understand how and why each patient responds to treatments differently and the way they do. Thank you.
Now it's my pleasure to introduce to you our guest for today, Dr. Bishal Gyawali. Bishal is a physician scientist, medical oncologist, and associate professor in the Department of Oncology and the Division of Cancer Care and Epidemiology at Queen's University. He has practiced medicine and conducted research in Nepal, Japan, the United States, and Canada, and is known internationally for his work in global oncology, evidence-based medicine, and health policy. Bishal is also the lead researcher on a project funded through the network's Patient Voices and Research Initiative, which unites patients, caregivers, and healthcare professionals to develop a patient-driven framework for clinical trial design. Welcome, Bishal.
Thank you very much. It's my pleasure to be here.
Okay. You practice oncology all over the world. What experiences have motivated you to become interested in precision oncology?
Yeah, you're right. I have practiced in different parts of the world, and I have seen disparities in access to treatments. I have also seen what value good cancer drugs offer to patients, and also some cancer drugs that may not be of high value to patients, but patients and the health systems sometimes they deprioritize important medications, but end up spending on medications that are not very helpful for the patients. So that whole idea got me interested in the philosophy of identifying the best treatment for the best patient. And we talk about precision oncology as, usually people talk it as it's the right drug for the right gene or the right biomarker. But I think of precision medicine even broader than that. It's not just the right drug for the right biomarker, but it's also at the right time. Some drugs are best used early on in the disease course. Some drugs are best used later on. Which drug to reserve for future? Which drug to use upfront? So right time, when to use it. Also right duration. Should we treat forever? Or should we treat for 2 years, 1 year, or just 4 cycles? What is the right duration of treatment? And also, what is the right frequency of treatment? Should we treat every 2 weeks, every 4 weeks, every 6 weeks? And this might come as a surprise to many. Also, the right dose. And I say this might come as a surprise because usually, from patients' point of view, I believe that patients will think that there is a huge scientific basis for why you use a certain dose of the drug. But in fact, classically, most of our chemotherapy drugs, and even now targeted drugs and immunotherapy drugs, we don't necessarily test for minimally effective dose, or we test for maximum tolerated dose. So to put it in a very blunt way, we are not testing the minimum dose that will lead to maximum benefit, but we are testing the maximum dose a patient can tolerate without getting really sick. So the way, we are talking about precision medicine and about finding the right gene and the right drug, but even our basics about, is this the right dose? Is this the right dose for everyone? Is this the right duration? Should we treat for 2 years for everyone? Is it the right frequency? Should we give it every 3 weeks, or maybe every 6 weeks is enough? Is it the right time? Should we treat right now, or should we save this drug for the future? So I wanted to look at precision oncology holistically, including not just right drug and right biomarker, but also all these other frameworks. And that motivation came because I worked in these different places. And just to give you an example, even in Canada, we have patients living in very rural parts of the country. And if we can give a drug every 6 weeks, then I think it's not in the interest of patients or the health system to ask them to come for treatment every 2 weeks. If you could give it every 6 weeks and achieve the same treatment, the same outcome. So it's more travel burden for the patient, it's more financial burden for the patient. And I guess that was my motivation to look into precision oncology, but in a broader framework than just right drug and the right biomarker.
Well, what you're saying really resonates as a patient. It's really, really resonating. Thank you for that. We usually talk to researchers about clinical research, but on top of being an accomplished oncologist, you're also a cancer policy researcher. Could you tell us a little bit about the role of a cancer policy researcher?
Yes, so you're right. I mean, there are not too many oncologists who do cancer policy research. And that's also a reason why cancer policy research does not often get funded. So I was very happy when I get funded from MOHCC and the Patient Voices in Research Initiative. So as a policy researcher, what we look into is the whole journey of a cancer drug development from preclinical stage up to phase 1, phase 2, phase 3 clinical trial. So how can we improve the efficiency in that system? For example, out of 100 cancer drugs that are being tested in phase 1, only 5 end up being approved eventually, right? So there is a lot of loss in the system, a lot of cancer drugs. They look very exciting at initial phases, but then they don't pan out when we test them in a trial. But as a policy researcher, my research does not end there. My research also looks into, okay, what happens, what leads to approval? Like, why are some drugs approved and why other drugs end up failing? And after approval, how it translates to real world outcomes. As in, after approval, how do we make decisions about whether, for a public health system like Canada, how do we decide we should fund this drug or we should not fund this drug? So we have Health Canada approval. What makes us decide? What makes Health Canada decide whether to approve the drug? And then we have Canada Drug Agency, and what makes CDA decide whether or not to give a recommendation for reimbursement? And then what are the financial implications of that, and how it eventually gets used in the health system? And so what is the time gap? And in fact, that is the research that I had proposed, is to look at those time intervals at all these stages, from Health Canada approval to CDA approval to actual use in the market. And also to look at, once we have started using these drugs, did these drugs improve outcomes in the real world as they did in the trials? Because in trials, we see very exciting outcomes, but sometimes they don't translate into the clinic when we use them in the clinic. And one of the reasons for that is the trials have very strict criteria for who can be enrolled in the trial. But when the drug is being used in the clinic, we use it for patients who may not always be eligible for the trial. So we see that a drug that shows great benefit in a trial ends up not showing as much benefit in the real world when we are using it in the clinic. So what are the reasons for those gap and how we address that gap, and the patient burden of this treatment, as in it can be financial burden, it can be time burden, and it can also be the supportive care needs that comes with the treatment, as well as even end of life care. Uh, do these affect patients' quality of life? How much it affects the quality of life, and does it affect patients' quality of life towards the end of life? So we study that whole spectrum with a policy lens, as in what are the changes that we need to do at regulatory stage, at Health Canada, at CDA, at reimbursement stage, at on the ground level, and then eventually how can we improve patient outcomes?
Thank you.
Thank you. What does common sense oncology mean to you, and how does it differ from the standard of care we see across Canada?
Yeah, so common sense oncology is a movement that we started in 2023, based in Kingston, Ontario. Me and my colleague, Dr. Chris Booth, we the reason we started this movement was, and the reason we named it common sense was, in most of the policy work and research work, we advocate for improved patient outcomes. We are always focusing on, yes, people say that we have 10 more drugs approved this year than last year. People say we have more drugs approved. We are spending more on cancer care. And our position has always been, that's all fine. But what we care about is, are our patients living longer and better lives as a result? All those developments have that translated into improved patient outcomes. And we want to see evidence of, yes, our patients are having better and longer lives as a result of all that development. And yes, we have had some fantastic drugs that have completely changed the treatment paradigm. But we also have a flood of very, very mediocre marginal drugs that end up causing lots of toxicities to the patient and do not improve quality of life or length of life. We want our drugs to do both, to improve length as well as quality. But you will be surprised that majority of our drugs actually end up doing neither. They neither improve length of life nor improve quality of life. And we said that's the minimum we should expect from our drugs, because these drugs have toxicities. These drugs cost in terms of physical toxicities, but also cost actual financial toxicity, and also takes important time away from patients. So if we are asking patients to commit their time to getting treatment, they should have some tangible benefits, which I should be confident as a doctor when I'm recommending a treatment to a patient. I should be confident in saying that, yes, you need this treatment, because if you get this treatment, you are going to live on average maybe 6 months longer compared to not getting the treatment. And those 6 months are not going to be 6 months in ICU, 6 months going to emergency, but 6 months where you can play soccer with your kids. That is our position. But when we look at this data with the policy lens, we find that most of these drugs are not hitting any of those benchmarks. And so when we say our drugs should improve our patients' outcomes, sometimes we get opposition saying that, oh, that's a very radical thought. We hear feedback like, that's a very radical thought. But in our eyes, no, that's common sense. Our drugs should improve our patients' outcomes. What can be more common sense than that? And so that's why we named it common sense oncology. And the basic grounding philosophy behind common sense oncology is the fundamental principle of cancer treatment should be that our treatment should improve outcomes for our patients. And because of that, the grounding principle for our research should be that we should be doing research, we should be doing trials that test for these outcomes. So yeah, that's the whole starting philosophy. That's how we started in 2023. We gathered almost 23, 25 experts from all over the world. This included patients, advocates, medical oncologists, radiation oncologists, surgeons, journal editors. We collected these major stakeholders, and we came up with a vision statement, with a mission statement, what it is that we actually want to achieve. And we published that we call it our manifesto. We published that in Lancet Oncology, where we outline that in order to achieve these goals, we are going to focus on improving clinical trial designs, so that clinical trial, once you have the answer from clinical trials, you can be confident that yes, this drug is improving life by this much amount, or improving quality of life. Because most often what we get from clinical trials lately is the trial is ended, and what we understand is, okay, the drug shrinks the cancer for a little while, but we don't know whether that shrinking has led to improved longevity or improved quality of life. Because how long a patient lives, how well a patient feels, it does not depend on the tumor size alone. Sometimes patients don't even know, like they have a 4 centimeter tumor in the liver, and then maybe the CT scan shows that it has shrunk to 2 centimeter. The patient has no idea. The patient knows that only because I tell the patient, your tumor is now 4 centimeter, it became 2 centimeter, or it became 6 centimeter. If that tumor is causing them pain, they will know. So the quality of life depends on where the tumor is. It could be just 0.5 centimeter, a very small cancer, but if it is in the brain, it matters a lot. It will lead to lots of symptoms, right? But it could be 2 centimeter tumor in the liver, and it may not matter because it is not causing any symptoms. In terms of quality of life, I mean, it will matter, of course, but in terms of quality of life effect. And it will also depend on the side effects from the drug. So quality of life depends on so many factors. So some of our drugs, they show that they shrink the tumor for 3 months, 4 months, and then it starts to grow again, or they shrink the tumor by some amount. But whether that shrinking tumor ultimately leads to improved quality of life for the patient or improved length of life for the patient, we don't know. So we are asking for better designed clinical trials. So at least once the trial is complete, we know these answers. And we are asking for less bias in how these trials are reported. Because previously, we used to have publicly funded trials done by academic oncologists and would be reported as it is. But now the entire drug development has shifted to industry. And so the industry is designing their trials, the industry is running their trials, the industry is analyzing their own trial data, and the industry is writing their own manuscripts, and the industry is publishing them. And every new drug approval is a billions of dollars market. So they have huge financial incentives in trying to paint a rosier picture of the drug than it actually is. So in fact, one of the things that we did at Common Sense Oncology last year was we produced a checklist of items that should be reported when someone reports a clinical trial result, so that we get all the information we need and there is no bias in reporting. So improving clinical trial design, improving the reporting of clinical trials, improving education among oncologists, because the things that we are having this conversation about today, most of the oncology training programs in the country that produces future oncologists, we don't talk about these things in the training program. We only talk about how to treat colon cancer, how to treat lung cancer, how to manage the side effect. We don't talk about how these drugs are developed and how these drugs are used, and what are the patient's priorities, and all these policy level issues. We don't talk about this. We don't even talk about how to read a clinical trial properly so that we don't fall into those biases and we understand the correct data. So improving the way we educate our trainees. So how can we improve our curriculum, and how do we communicate? And that communication is with reaching out to patients and patient advocates so that we can have these type of conversations, and also communicating with the media, because media plays a big role. You see these sensational headlines almost every month that there is a new drug that cured brain tumor. There is a new drug that completely cured bladder cancer. And then you read in detail and it's in mice, or it's a case report in one person, right? And you don't know, like maybe they tested that in 1,000 people and one person responded, and they're just highlighting that one person out of 1,000. Or in most cases, it's in mice, and the probability of something effective in mice that ends up being effective in human patients is very, very low. But patients, when they read that news article and says pancreatic cancer has been cured, then they might feel like, oh wow, I need this drug tomorrow. But once we read into that, it is in mice and that drug is not even available. So all these issues is what we are trying to address with our common sense oncology movement.
Thank you. I'm interested in hearing a little bit your thoughts on the relationship between precision oncology and your concept of common sense oncology. You used the a phrase a little earlier about kind of in real world care. So, how do those two things fit together in real world care for a patient?
Yeah, so I think, at the beginning I mentioned about I think about precision oncology in a more holistic way than just matching the name of a drug to the name of a biomarker. So for me, where common sense oncology and precision oncology intersect is in identification of really high value drugs from other mediocre drugs. Because if it is a very high value drug, we need access to that drug as soon as we can. Um, and so we need to have that distinction. And so how can we distinguish between really high value drug with not so high value drug or mediocre drug or even harmful drugs? Uh, and that is going to be quite important as we move forward because you may have noticed that, for example, Ontario is introducing this FAST program to fast track some drugs. So how do we make sure that we are fast tracking the right drugs? We don't need fast tracking of harmful drugs, right? So when we are fast tracking drugs, how can we make sure that these are the really good drugs that are being fast tracked? Because yes, we need access to drugs as soon as we can, but we don't need access to any drug. We need access to drugs that are going to improve outcomes. So one is in that sense of identifying or differentiating between high value drugs that we need access today versus other mediocre drugs. And the second one is in my holistic approach to precision oncology, because patients have informed that it's not always about, we talk about patients as if patients is one entity, but patients represent a spectrum, right? So we come across patients on one end of the spectrum where some patients tell me that they want to do absolutely everything they can. They want to try every new drug, like absolutely everything they can do to extend life even by 1 week, right? And we are not here to put a price on life or a price on what is important. For some patients, that is absolutely important. That 1 week could be an extra week where they can attend wedding of their daughter. Whereas we also, on the opposite spectrum, we also have patients who say, in the far opposite spectrum, we have patients who deny all care altogether. But also on the normal spectrum, on one end, we also have patients who say, I'm happy to take any treatment as long as it benefits me. If you are confident that I'm going to get cured by taking this treatment, yes, I'm okay to suffer some diarrhea, some side effects if I'm going to be cured. But if it's not going to cure me, or if it's not going to lengthen my life, or if I'm going to spend my days feeling very tired and bedridden, then I don't want it. If you say it's going to improve my life, I'll try it. But if it's not going to improve my life, I'm not going to take it. So we have a spectrum of patients with different priorities. And for patients, it becomes not only important about whether how big the tumor is, or did we shrink the tumor, but also all these other ancillary matters, as in travel time. How often should I come to the clinic? how much of burden it is. For example, we talk about side effects in our scientific language. We call grades of side effects, and we say, okay, grade 2 is not a big deal, grade 4 is a big deal. But if we talk with patients, like grade 2 diarrhea is a big deal. Like if you get grade 2 diarrhea for every day, that is a far bigger deal than having another grade 4 side effect that lasts 1 or 2 days. Uh, so patient priorities come into play. And as I explained earlier, the way we are treating currently, the way we are choosing dose, the way we are choosing how long to treat, the way we are choosing how frequently to treat, and the way we are choosing when to treat, these are not very scientific. We are using the maximum dose, even though that may not be the right dose. We are treating patients, for example, with immunotherapy. Just to cite an example, now there is plenty of data showing that we can use a lower dose of the drug and achieve same outcomes. But we have been using almost 10 times more dose than what is needed. And also in advanced cancer setting, especially with immunotherapy and targeted drugs, we treat them until the patient tolerates or stops to tolerate, or until the cancer starts to grow again. But is that the best way? Like, we have not studied that. Maybe you can treat for 6 months, and maybe the cancer will, if it is destined to grow after 24 months, whether you treat it for 6 months or whether you continue to treat for 24 months, probably I'm just making a hypothesis, random hypothesis. Probably it does not make a difference. So should we treat for 2, 3, 4, 5 years, or can we stop the treatment after 1 year? In curative setting, as in adjuvant treatment, we now have plenty of data showing that a shorter duration of treatment is as good as the longer duration of treatment, but with less side effects and with less burden for the patient. We also have some data showing that giving treatment before the surgery for 3, 4 cycles is probably as good as giving the treatment after the surgery for 1 year. So in terms of finding the best or the optimal treatment for the patient, the optimal dose, the optimal duration that minimizes burden for the patient but achieves the optimal outcomes, I think that is where common sense oncology and precision oncology intersect, and so that we can find what is best for our patients, for patients on the entire spectrum, that addresses needs of the patients on both the ends of the spectrum.
I think you actually answered my next question. So I was going to ask you a different question, but right now I'm curious if you have given any thought to how you can measure quality of life before you give patients treatment, and if you're going to develop it into a standard that would be given to clinicians.
Yeah, so measurement of quality of life is one of the messiest topics in clinical trials, because survival is pretty easy to measure, as in someone is either alive or not. So there is no bias in measurement. But quality of life assessment, it's not such a hard endpoint, as in we need to ask the patients how they are feeling, and the patients fill out a list of items on a questionnaire, and it can depend on many factors, including what the patient is feeling on that particular day. That has a heavy influence on how the patient is going to answer that questionnaire. Even if, let's say, the patient is feeling great before and after, but on that particular day, for some reason, the patient is not feeling very well. And the tools that we have developed to measure quality of life, and these are standardized, validated tools that are being used in clinical trials. But there are also now questions about, if you look at the drugs that are approved, almost all of them like 99.9% of the cancer drugs that are approved, they're approved on the basis of these survival and response endpoints. Very few drugs are approved on the basis of quality of life endpoint because it's very difficult to measure. Organizations like EORTC, they have developed these standardized instruments. They call it instruments, that just those validated question tools that we ask patients at different time frames, before treatment, during treatment, after treatment, to see how their quality of life has changed or evolved over time. But again, there are a number of issues with the assessment and with the reporting, as in when we measure quality of life, and when do we stop measuring quality of life? Because if the drug has long-term toxicities, for example, some of our drugs cause nerve damage, and that nerve damage can sometimes be permanent, as in patients can have impact 5-10 years after treatment. But most of our trials don't collect information that far down the line. So we only get a small snapshot of quality of life information from those 24, 36 months that the trial captured those data. And there is also an issue about many patients not filling out the questionnaires. So there is a lot of missing data. So quality of life measurement is tricky, and Common Sense Oncology has collaborated with EORTC. This is the European organization that initially developed and validated these quality of life tools. And so we are working on making it more robust and reporting it in a more robust way, so that we can get a clear idea of how much quality of life impact the drug has on the patient. But it is a very difficult and messy topic. It's not easy as measuring the tumor size and saying it's 4 centimeter and it's 2 centimeter. It is very difficult.
I think it'd be super helpful for patients to hear your thoughts around, from a common sense perspective, what kind of questions would be good for a patient to ask when a new treatment's being offered?
That's an excellent question. Because we have thought about this. We have a patient group within Common Sense Oncology, and one of the projects that the group is working on is developing a list of questions the patients can use to ask in different situations. Like, we have a list of questions that patients can ask before enrolling into a clinical trial to make sure that that's the best clinical trial for them, and a group of questions patients can ask when they just got a diagnosis of cancer. And I think what you just asked me is just before they are starting on a new treatment. So that was your question, right?
I think, yeah, that's exactly it. And it's kind of all of the above on those things,
Uh-huh.
those questions from different
Uh-huh.
different points along the journey.
Yeah.
Yeah, your thoughts would be wonderful. Yeah.
Yeah. So I think at the point of diagnosis, the most important questions to ask would be what stage of cancer it is. Of course, I'm assuming that what organ, what, like, is it pancreatic cancer or breast cancer? I think it's a given that the oncologist will tell the patient. So beyond that, I think it is important to ask what stage of cancer it is. Is it curable? Like, what is the goal of treatment? Is the goal of treatment to cure the disease or to prolong survival, improve quality of life? What is the goal of treatment? And what are all possible treatment options for that? Like, the oncologist may be suggesting let's do treatment A, but are there treatment B, C, D, E options available? And what are the benefits of choosing A over B? And so that the patient can make sure that whatever benefits and side effects are discussed aligns with their preferences. And I guess the other important question, and as I said, we are going to formalize this and we are going to publish this. The patient group is working on this. This is just me saying it off the top of my head. And the other important question to ask would be, what are the side effects to expect, and the follow-up plan, as in how we judge the benefit of treatment. Is it by doing scans? Is it by uh, asking how? Is it by how I'm feeling? So how do we measure the benefit? How do we know that the treatment is still in my best interest? And at the time of uh, uh, and if we're talking about at the time of diagnosis, some other important questions to ask would be, is it something that is running in my family? Or is there a genetic test that I should undertake to understand the prognosis, as well as uh, in scientific language, we call it prognostic biomarker and predictive biomarker. What that means is running some tests to tell me whether my cancer is more aggressive than others' cancers, so that I can get a sense of life expectancies. When we're talking about life expectancies, nobody can give an exact number. So we're always talking about ranges. So when we're talking about a range, to get an idea about, do I fall on the lower end of the range or on the upper end of the range, if there are prognostic markers that can help me to have that understanding. And the other is, I call it predictive marker. That means there are certain, especially for precision oncology, there are certain tests that we run that can tell us whether someone is more likely to respond to a certain treatment, or even less likely to respond to a certain treatment. And then the third marker, which is usually, when we test for these two markers, we usually understand that by itself, is whether it is running in the family. And that is important to counsel your family if they need more screening, or if the family needs to do something about it. So I think those are the most important questions to ask at diagnosis. At the time of treatment, I think we already discussed about what are the possible treatment options. Why should I choose treatment A over treatment B? Is not doing anything an option? Because sometimes, contrary to belief, like, treatment is important, but we talked about right time to treat. Sometimes, depending on the situation, you may not need treatment immediately. You could probably wait for 3 months, 6 months before starting treatment. And that could be 6 months of good quality of life that you could enjoy before starting treatment. So what are my options? Is not doing treatment right now also an option? What are the goals of my treatment? How do I judge that the treatment is working for me or not? Is it based on how I'm feeling, or is it based on a scan, or is it based on a blood test? And how long should I continue this treatment? And if this treatment does not work, what are my subsequent line options? Do I have other subsequent line options or not? Is there a clinical trial for me? Because getting into a clinical trial, a well-designed clinical trial, is always one of the options. So I think, and one thing I wanted to mention here, tying to my experience of working in different countries, sometimes I feel there is a cultural component to treatment and how patients think about cancer as well. Because I have noticed, for instance, I have worked in Japan, and in Japan, I can't generalize. Of course, there are always a spectrum of patients, but there is a cultural acceptance towards the concept of death and dying, and it does not feel as a taboo subject there. Like, you can talk about death, you can talk about dying. In Canadian context, it feels more like a taboo, and sometimes I hear from uh, families who have come with the patients in the clinic talking about, Dad, you can't give up, or, Mom, you have to fight this. We are going to beat this. So that whole idea about cancer being an enemy that we have to fight, and if like, even towards the end of life, or even after 5, 6 different lines of treatment, when it is almost certain that continuing on treatment might be harmful for the patient, even at that point, just because of the concept of not giving up, or I'm going to fight this, um, I see some patients unnecessarily suffering towards the end of life. So there are those cultural nuances too.
Yeah.
And if it feels okay for the patient, then I would highly encourage patients to talk about longevity, prognosis, and end of life, what it is going to look like before such things start to happen. Because what happens sometimes is patients don't want to talk about these things, and suddenly when things go wrong, they are in emergency, and they need to make these discussions with a doctor in emergency that they have never seen before. It would have been far better if we could have that conversation with the oncologist that we have seen for 2, 3 years. You have a rapport and you could discuss these things more openly, and so that we know what the preferences are. But sometimes we see that we can't have those discussions, and suddenly the patient is in ICU or in emergency and needing to make those decisions.
Thank you. So very insightful. It's been really great, Bishal, to hear about your patient-centric and equitable approach. Thanks for chatting with us today. I'm sure, speaking for Bev and I, that your work is really bringing realistic hope to patients like us. Thank you.
Thank you so much. It means a lot. And I apologize if in my conversation, if I use technical terms, if I sounded sciencey, uh, but I really appreciate this opportunity to connect with you and to share my thoughts.
Your
Because
vision was
I
quite
believe
clear.
that more people should be aware of this type of research that we do, because it does not make news all the time. What makes news is we found a new target, we found a new drug. That makes news all the time, and that is what gets funded all the time. But I personally believe that the type of work we do are important for the patients.
Yeah, thank you.